I think exercise is underrated. Again, I don't think most people fully appreciate how much a well-structured exercise program is going to change their life. Not just in the here and now, but in terms of what it means to how well you will live that last decade of your life. And nothing, I think, provides a greater backstop to avoiding those traditional pitfalls than exercise.
So you've often said that exercise is the single most powerful lever we have for both lifespan and health span. Why does that continue to hold true above all else?
I assume you're not asking me why am I saying that, because I think the data are pretty clear on that. I think you're asking more the meta question, and I don't think I have a great answer for why that is the case. It probably has to do with the fact that exercise impacts so many systems, and so when one is physically active, many things are happening. But that's not really a good answer either. That's just sort of kicking the answer down the road a little bit. The broader question would then be, well, why is that the case? And so I think you could keep asking why a lot of times, and I'm not sure that at least I could get to the root of why exercise is so potent at improving length and quality of life.
Do you think in the next decade or so, we'll have more of an answer?
I don't know, and I don't know that it is answerable. I think in the next decade, what we will have is better mechanistic insight into why it's happening. In other words, we'll understand more of the pathways that exercise is favorably acting upon, and by extension, this will lead, I suspect, to a lot of interest in the pharmaceutical space around trying to replicate pieces of exercise, the so-called exercise in a pill approach. My intuition is that while that may yield some fruit, it will still not yield the complete fruit of exercise. And so I kind of doubt that even when various molecules and pathways are discovered that are potentiating the favorable effects of exercise, I suspect that they may have an impact on chronic disease. I don't think they'll capture the full benefits of the health span side of it. I just don't think there'll be a substitute for actual training. Even if you put on muscle mass, right? Because there'll be drugs presumably that can just give you muscle and give you strength, even absent training, potentially. I think it'll be much harder to reproduce some of the movement benefits that come from exercise and things that require specificity towards the activities that we like to do. But again, we're in the realm of sci-fi when we're talking about it this way.
Understood. Very fair. So in terms of today, VO2 max, long been one of your favorite core metrics for predicting longevity, still at the top of your list, or have your views evolved?
Well, I would still say that VO2 max is the best predictor of lifespan. I haven't seen anything that's displaced it yet. That doesn't mean it's the best. We just have to remember that it happens to be something that is quite standardized. It's quite easy to measure, and we have a lot of data for it. But there could be something else that is more predictive that we just haven't, picked a measurement for. It could be that functional threshold power is a better metric. I'm, of course, making this up. But we don't have reams of longitudinal data for lots of people and their functional threshold power the way we do for VO2 max. And also it might be sort of splitting hairs. It might be splitting hairs a little bit as to whether VO2 max or strength, and it usually is in that order, VO2 max first and then strength, muscular strength. But I think the point is that those two really stand out from virtually anything else, including, hypertension, hypercholesterolemia, things that we know are quite negative. Being weak and being unfit are really, really bad things.
So in terms of your VO2 max protocol today, how are you currently training? What does your structure look like? If we look at frequency, duration, are you doing, the Norwegian 4x4? Are you doing walk us through what a week, and I understood that weeks could vary.
Yeah, I do try to vary it a little bit more these days. So on Saturday, I try to always do my VO2 max workouts on a Saturday, just for a number of reasons. So this Saturday, I did 3 sets 3 push sets at 8 minutes. So 8 minutes at sort of my hardest 8-minute effort. But I actually did it as part of a loop that I ride where it's a 10-kilometer loop, but the loop ends with a climb that is about 8 minutes. So I'm riding the loop at a reasonable pace, but again, much of that loop is downhill and flat, as evidenced by the fact that the last 8 minutes is uphill. And so 8 minutes at a hard push is sort of the upper limit of where you're still activating a VO2 max system as opposed to a more longer aerobic system. And so, yeah, I'll do, on a day like that, I'll do 3 or 4 sets of 8 minutes. On another day, I'll do, maybe 6 rounds of 4 minutes. But I'm sort of trying to get 25 to 30 minutes of very, very hard effort. I'm, about to start reintroducing swimming, so I might actually introduce a second kind of higher intensity workout each week and do one of the swim workouts at higher intensity as well. And that'll be probably in the neighborhood of 2 to 4 minute intervals. That'll be at, kind of a VO2 max pace.
So, how do you define that hard effort? So, me, for example, I'll look at my whoop, I'll look at my heart rate. It's imperfect, but for me, it's a gauge of how I'm progressing. Do you have a hard and fast rule for how do you define that? Or is it more about feel? How do you look at effort?
So I think that a couple things are, heart rate can be quite misleading. So my VO2 max efforts from week to week can vary by 10 beats per minute on heart rate. So I don't tend to use heart rate at all to guide exertion. I'm guiding exertion by RPE, rate of perceived exertion, and the ability to hold a constant effort. So, the nice thing about a bike is you have a power meter, and the power meter doesn't lie. It's going to tell you exactly how much work you're doing independent of how you feel. And so while week to week I might see differences in those power numbers within a given week, I'm trying to hold the same power for the interval. And so if I go out and do my first interval, and at the end of that interval, having held the power constant, I think that wasn't hard enough, then I'm going to take it up a notch for the next interval. Conversely, if in a given interval, I can't maintain that power for the full 4 minutes, and in the last minutes, I completely fall off, then I know I went out too hard and I drop it. So what I'm aiming for is a constant effort over the interval, not a constant feeling. So if you're doing it right, I always tell my patients, if you're doing a 4-minute interval at constant effort and that effort is very hard, it's your maximum, it's your best 4-minute average power, the first minute's actually going to feel pretty easy. By the second minute, you're starting to hurt, and by the third minute, you're in a lot of pain. So it's quite nonlinear. You're going to do, I describe it as you'll do about half the effort in the last 25% of the time. I also just want to make sure we're not overcomplicating it for people who aren't nerds. And so, I really do enjoy this type of physiology. And I'm also really, really optimizing for making sure I'm getting the maximum benefit out of the workout. But if you're less than perfect doing this, you're still getting a lot of benefit. So I don't want people to sort of throw out the idea that, well, if I'm not willing to be as sort of nuanced and detailed as that guy is, I shouldn't be doing it. No, no, no. The answer is you should be doing it. And you don't need a power meter and you don't need a heart rate monitor, and you can just go off exertion. And yeah, it might not be you might not be operating at 100% efficiency. You might only be getting 80% of the efficiency that you could for the time you're putting in, but that is still fantastic.
I couldn't agree more. And I've definitely found that there's a disconnect between my heart rate and exertion. And sometimes heart rate goes very high for me and I'm not really feeling the exertion. And other times I can't get the heart rate high enough and I'm gassed. And so shifting to strength, how are you approaching resistance training these days in terms of frequency, volume, and goals? What does that look like?
I'm in the weight room 4 days a week. And so one day a week is a lower body day. One day a week is sort of chest and back. One day is arms, shoulders. And then there's one day that I just do dedicated around all things that pertain to carrying. So that's sort of actually my most fun workout. I always do that one on Sundays. And if anyone ever says, "Hey, Peter, can I come and join you for a workout?" I usually invite them to that one, because it's the easiest one, I think, for a person to pick their own weight and their own level and not, not be terribly taxed the way they would if they were gonna join me for, like, say, a leg day. And I don't know, there's just something about it, it's really enjoyable. So I do a bunch of carries and just a bunch of, other exercises that are really all about strengthening grip. That's kind of how I'm dividing my time in the weight room. And obviously, if you're only gonna do each body part once per week, and there's a little bit of overlap because I also do quite a bit of grip and carry stuff on one of the other days as well. And I tend to do a little bit of back, like on my leg day, I always do a set of 10 pull-ups between every exercise. So I'm kind of hitting back twice technically, but you've got to hit a certain volume. So I'm trying to make sure I get at least 12 sets per body part since I'm only hitting it once per week. And the intensity is never less than 2 reps in reserve, usually closer to 1 rep in reserve.
So, have I heard correctly that you've moved away from heavy free weights and deadlifts and doing more machine-based work? Is that accurate?
It is true that I have stopped doing deadlifts and back squats. Yeah, but otherwise, I'm heavily relying on free weights. I do use some machines. I have a belt squat machine, so that's obviously a machine, although you're loading it up with plates. But yes, I about a year ago, maybe even more than that, but I think about a year ago, I sort of, just started displacing squats and deadlifts with more single leg exercises and belt squats also, which are not single leg. And yeah, for me, that's just been a great decision. It hasn't really cost me anything, but it's given me just you know no bad days. Whereas I think before I would, you know 1 in 10 lifts, I would just push a little too hard, or maybe I just wasn't quite rested, or my form just wasn't quite right, and I would sort of just, you know, tweak my back. Which again, there's nothing, catastrophic about this. I also think it's important that people don't catastrophize when their back goes into spasm. It's just a protective thing, right? It means that the muscles in the lower back have sort of said, "Hey, I don't like the way you moved. I'm going to kind of cinch down and make sure you don't do anything stupid again for the next couple of weeks." And of course, you're fine after that, and it's okay. But you have to heed the warning. And I just realized that at my age and my stage of life, and for my goals, I wasn't really getting anything out of it other than the enjoyment of the exercise. But that wasn't enough for the risk for me, so just moved on.
100%. The only time I've gotten in trouble in the weight room, clean and jerk way back when in college, and recently deadlifts. And it's a situation where maybe I'm trying to go a little heavier and then I sacrifice form and, maybe I tweak something. I'm fine, but I'm laid up for a couple days and then I can't be in the gym. I can't be working out and I'm annoyed. And at this point, I agree. Like, I just don't want to be bothered or risk being being out for any period of time.
Yeah, and look, I know a lot of people who, including many of my patients, who get so much joy out of these compound movements, and for them, it's worth doing, and that's great. But again, I do think it's a mistake to assume that you have to do these movements to get the full benefit. Again, I still do very, very heavy single leg RDLs. I do very, very heavy split squats. I do lots of very heavy things that don't put as much axial compression on me. And again, it's just been kind of blissful to experience the total lack of discomfort for the past year.
So, do you think one can reach a point of diminishing returns as it relates to exercise, whether it's cardio or strength training?
Oh, for sure. Again, it depends on a couple of factors, right? It depends on how intelligently a person is training. So to take one example, if you're trying to win the Tour de France or you're trying to go to the Olympics, yeah, there's a diminishing return, but make no mistake about it, the mere mortal isn't getting anywhere near it, right? Like if Tadej Pogacar could win the Tour de France training 12 hours a week, he would train 12 hours a week, right? There's a reason that the best endurance athletes in the world are still spending, you know, 25 to 30 hours a week doing their endurance sport. Now, again, people have to understand that 80% of that volume is at what is for them a very low intensity, typically zone 2, but it's also worth noting that their zone 2 is my zone 5. So, I mean, the pace that, Pogacar can hold for 5 hours, I can hold for less than 5 minutes, and that's actually not an exaggeration. So we just have to sort of make sure people understand that we're talking about this conversation has to be in the context of your goals.
Let me rephrase it a different way. So, when do you know when to back off to maybe say, you know what, today's going to be a rest day. I need to take it easy. Some people leverage wearables. They're in the red, or it's a feeling. Like, how does Peter Attia know when to, you know what, I need to like dial it back?
Yeah. So again, I'm in a different situation from a professional athlete. I'm older, I'm more brittle, and I have far more stress in my life. Not that professional athletes aren't stressed, but their whole job is their thing. I have 4 jobs, 3 kids, other priorities, and those things come with more stress. And that stress, the body doesn't really have a great way to distinguish between that stress and the stress of exercise. Like, it's all stress to the body. And stress is good to a point, but at some point it becomes counterproductive. And so I don't rely on any wearable to tell me when it's time to exercise or not exercise. I don't believe there's a single wearable on the planet that can even come close to doing that with any meaning. I think the way you feel probably trumps every single wearable out there, provided you have some sense of historical, reference in training. So I don't know that that would be true for a person who's never exercised. But if you took someone like you or me, who have spent their lives exercising, and by the way, that's also true at the level of the highest pros. I mean, I know this because I talk to them and I talk to their coaches, and they are not relying on wearables to tell them when they should be backing off. They're doing it based on how they're feeling and how they're performing. And by the way, if you're going to add any metric to this, I'd look at morning resting heart rate, which you don't need a wearable for, right? You can measure your resting heart rate in the morning. And when that starts spiking, it could mean that you're sick. It could mean that you're overtrained. And that's probably going to correlate with how you feel. So I don't use those things to guide my training. Sometimes things are forced upon me if I'm traveling, or if something else comes up. But for the most part, I just let how I feel guide how I train.
Understood. So, if we segue to cardiovascular health, cardiovascular disease still remains the leading cause of death. Last time we talked about ApoB and LP little a, two most critical biomarkers to track for cardiovascular risk. If I think of Outlive and all the amazing information you get out to the world, I think of ApoB and LP little a at the top of the list. So is that still the case? And if so, ideally, where do you want those numbers to be for people listening?
Yeah, LP little a is hereditary, so it's something you don't need to check as you don't need to check it frequently the way you would ApoB. And we kind of divide people into sort of low, medium, and high based on their level. And while there are several drugs in the pipeline that have shown that they can reduce that level, it still remains to be seen if pharmacologically eliminating LP little a or taking LP little a to very, very low levels translates to positive outcomes with respect to what are called major adverse cardiac events. I suspect it will, but as of this moment in time, we don't really have an action that we take directly against LP little a. And so what is considered low depends on the units of measure. So if it's being measured in milligrams per deciliter, then low would be below 30. And if it's being measured in nanomoles per liter, then low is typically considered below 75. So of course, everybody should make sure they know which units they're looking at to figure out where they stand on that. As far as ApoB goes, how low you want it, I think is a function of what other risks you have and where you are in life when you're making the decision to intervene. Because cardiovascular risk is driven obviously not just by ApoB, but by other factors, blood pressure, smoking, insulin resistance, and LP little a. And it's kind of about the net accumulation of ApoB. So you can sort of think of it as the area under the curve of ApoB exposure over life. So we're all born, most of us are born with a pretty low ApoB, and it just sort of slowly rises throughout age. And it is quite influenced by our genes. Obviously, insulin resistance and dietary composition also impact it, but genes play a pretty significant role. And so if an individual shows up in their 30s with a slightly elevated ApoB, but no other risk factors, only a mild correction might be needed. Putting them at the 5th percentile, which would be about 60 milligrams per deciliter, would be more than satisfactory if it were to maintain that for the rest of their lives. Conversely, if you take a person who shows up with multivessel disease, coronary artery disease, and/or they've they show up and they've got an ApoB that is significantly higher, they've had much more exposure, then you would probably target a more aggressive, low target for ApoB.
Jason Walkup here, founder and co-CEO of mindbodygreen and the host of the mindbodygreen podcast. Please subscribe. You'll never miss a show and you won't regret it. Well, how would you assess the burden over time? Is it clearly that's the gold standard? Does one resolve to imaging to understand how the ApoB has been building up over time to then assess whether or not a pharmaceutical intervention would make sense to lower ApoB? How do you think about that?
Well, I mean, imaging studies are only able to really demonstrate pretty advanced disease. So you can do a CT angiogram on somebody, but you can't actually, even with a test of that resolution, see anything beyond soft plaque or obviously calcification. But again, both of those things happen many, many years after exposure. So unfortunately, that's the best we have, right? Is we can look at the evidence of damage and say, well, boy, if you have soft plaque here, or if you have calcification, or you have even occlusion or narrowing of coronary arteries, yeah, I mean, at that point, you have coronary artery disease. Alternatively, I think the other approach, and the approach that we take, is that you treat causal markers of disease regardless of the presence of disease. And the example I think I gave in the book is that of smoking, right? So for some reason we've figured this out when it comes to smoking, which is in other words, we act very rationally around this, right? We know that smoking is causally related to lung cancer. And what does that mean? It means that there is a relationship where if you smoke, the probability of you getting lung cancer is much higher than if you don't smoke, and that is attributed to the smoking itself. That is what I mean by causal. Now, does every smoker go on to get lung cancer? No. Does every person who get lung cancer smoke? Have they smoked? No. 15% of people who get lung cancer never smoked. So just because something is causal doesn't mean there's a one-to-one mapping from it. And it's important to point that out because everybody likes to point out their grandmother who's got high LDL cholesterol and high ApoB and doesn't have heart disease. Yes, that doesn't in any way fly in the face or challenge the causality of ApoB. The causality of ApoB and LDL cholesterol has been established in tens, if not hundreds, of clinical trials and Mendelian randomization. So it's really not a point of debate. And therefore, if we know that, the question should be, why wouldn't we lower ApoB in everybody, given that it is causally related to cardiovascular disease, not associatively related to it, but causally related? And that's our view, is that everybody's ApoB should be low. And if it's low naturally, wonderful. And if it's not low naturally, then you do need to lower it pharmacologically. Pharma is not like great on all things. In fact, there are many things that pharma is really pretty lousy on. But if there's one area where pharmacology is overperforming, it's in cardiovascular disease, right? If you look at the suite of drugs that can lower cholesterol today, it's unbelievable compared to what was available 30 years ago. If you look at the suite of drugs that can lower blood pressure today, it's unbelievable compared to what was available 20 or 30 years ago. So I think we should take the win on cardiovascular disease and say, why are we still letting people die of this disease? Like, this should be an orphan disease. Nobody should be dying of this disease. And yet somehow 19 million people a year find a way to die from this condition. Hands down the leading cause of death globally in the United States for men, for women, and it's just totally inexcusable.
And pharmacologically, you can completely take it off the table.
Yes, we can just take this one off the table. There's simply, I mean, we should be able to go from 19 million to 19 people.
And so a couple follow-up questions. How do you define low ApoB? And then what do you look to for pharmaceutical interventions these days in terms of is it Zetia, is PCSK9 inhibitors, statins, newer agents?
Yeah, so I mean, I think how low you need to go again is a function of all the things we've already talked about. So it's where are you starting at? Um, what's the evidence that you have disease already, and what's the significance of it, et cetera. As far as the drugs, you have several classes, right? So you have statins, which target an enzyme that is an important enzyme in the synthesis of cholesterol. Statins target this enzyme across the body. And so they're very potent because they really suppress cholesterol synthesis. But that's not so much why they're working. What they're working, the reason they work is because by suppressing cholesterol synthesis so much, the liver reacts and says, I need more cholesterol. And what it does is it upregulates what are called LDL receptors on its surface. So the receptors, the LDL receptors bind to the LDL particles, which are surrounded by the ApoB. So that's what they're binding to. And they pull these things into the liver so that the liver can have more cholesterol. And the net effect of that is that it lowers the concentration of ApoB or LDL in the periphery. So that's how they work. And there's, you know, 9 of these drugs out there if you go back in time to the OG version of this drug from the late 80s, early 90s. But these days, there's really only 2 that are commonly used, except for patients who have been on, you know, Zocor for 100 years, and they're going to continue to be on it. But these days, most patients are either going to be taking atorvastatin, which is Lipitor, or rosuvastatin, which is Crestor. And something that most doctors don't know, and I think certainly most patients don't know, is you really never need to be on a high dose of these drugs because the dose response curve for these things is very, very convex negative, right? So it's concave down very sharply. So you get virtually all of the benefit in the first iteration and second iteration of the dose. So when it comes to rosuvastatin, which is dosed at anywhere from 5 to 40 milligrams, you're getting about 80% of the maximum benefit at 5 milligrams. So when you go from 0 to 5 milligrams, you're going to get 80% of your reduction of LDL cholesterol. Going from 5 milligrams to 40 milligrams gives you the last 20. And guess what? It gives you the most side effects. So there was a day when we needed to do that because we didn't have any other drugs. But now that we have other drugs, at least in our practice, and I think for any practice that's sophisticated, I'd much rather have you on a low dose of 3 drugs or, a low dose of a statin and 2 other drugs than just maximize your dose on a statin. You mentioned ezetimibe. That's another great drug that's been around for about 15 years now. It works by inhibiting the reabsorption of recycled cholesterol in bile in the gut, which again is part of its effect, but the main effect of ezetimibe is actually the same thing as that of the statin, which is the liver is not getting back that biliary cholesterol. And what does it do? It upregulates LDL receptors again, and it pulls more LDL in. You mentioned PCSK9 inhibitors, probably the most potent of the lot. These, as their name suggests, inhibit a protein called PCSK9. PCSK9 is a protein that degrades LDL receptors. So if you inhibit a protein that it degrades LDL receptors, lo and behold, you have more LDL receptors on the liver. So again, it all points back to the liver's ability to clear LDL. And then the other drug that is out right now is a drug called bempedoic acid. And bempedoic acid works a lot like a statin, except it only works in the liver, meaning it doesn't inhibit cholesterol synthesis throughout the body as a statin does. It only does so in the liver. And therefore, it's not as potent, but it also doesn't have any of the side effects that statins have. So statins, if there's anything wrong with statins, it's that they tend to have more side effects than any other class of cholesterol-lowering drug. The 2 most common side effects are muscle soreness and insulin resistance. I actually, it's funny. I don't know if we ever got around to publishing this, but we did write a piece about the insulin resistance in statins, and it turns out that it's still a very net positive effect. So even if you look at all if you look at the increase in insulin resistance relative to the reduction in LDL, it's still a positive effect on mortality, but it's also less necessary today. I think we just don't need to push people that high on those doses. The next class of drug we're going to see will be a CETP inhibitor. So there's a drug called obicetrapib that is just being approved right now in Europe. This looks to be a very exciting drug. It's not only incredibly potent and incredibly well tolerated, but it also appears to have another benefit, which is that it appears to reduce two important biomarkers of dementia,
Which biomarkers?
amyloid beta and p-tau. So it has lots of metabolic effects, favorable metabolic effects, along with these potentially cognitive effects. So I think we could, in the next couple of years, look to add obicetrapib to the list of drugs that we could use to lower cholesterol.
Interesting. I'll just segue quickly. So to p-tau and neurodegenerative disease, I feel like there's been an explosion in terms of awareness around p-tau and general neuroinflammation and the markers people should be on the lookout for. How are you thinking about that?
Well, I still think we're kind of waiting a little bit to see what's validated. I think AB42 and AB40 are, I think there's value in those assays, and I think p-tau as well. Again, I think the challenge and the thing that people need to remember is whenever you're looking at a biomarker, you have to be careful that you don't overinterpret it without understanding the patient population in which it was validated. So if a bunch of studies are being done in p-tau that are being done only in people who are cognitively impaired and or people who have dementia, and that's what sets the boundary conditions on the biomarker, I would be personally very concerned with ordering that test on someone who's completely normal, because you have no idea how to interpret that test. And so it is not our practice to order these tests routinely. And instead, we would order these only in very select situations under high risk.
So anecdotally, I'll just share my experience. So I do all the testing. Out of curiosity, I want to learn. So I came back high on the p-tau, the amyloid totally normal, the AB all normal. COVID was high, the spike, and it was correlated with the spike, the p-tau spike, along with the COVID inflammation from a prior infection. And my point is similar to your point in that if I were just doing the lab and I didn't do the COVID test and I didn't do the AB test, I would be absolutely freaking out that my p-tau level, I have no symptoms, no genetic, no anything, no lifestyle. But the context with doing the other labs, not so concerned. I got to wait till the COVID, completely clears out of me. And I think that's also an interesting field right now because that's the great unknown. We don't really know what's happening there.
Yeah, I mean, I have not done either of those tests on myself, and I don't have any plans to. So,
And just to close the loop on cardiovascular disease, 'cause I think this is a profound point. If cardiovascular disease is the number one killer and plaque builds over time, there is no reason at some point not to take any one of these pharmaceutical interventions, whether it's something low dose, pretty benign, no side effects. I can't say as a Tembe, I just say the Zetia that breaks. I just can't. I have a mental block. I can't do it, Peter.
Zeti is fine.
Exactly. There you go. You don't have to do the statin, which has side effects, and you could completely rule that out, which I think, at least for me individually, where cardiovascular disease runs in my family, that's tremendous peace of mind for someone. And I agree that pharma actually does quite a good job here, and pharma is far from perfect.
Yeah, yeah. Pharma is far from perfect, and yet here they've given more tools than they've given anywhere else. And I'm constantly amazed at how there are just a whole collection of people out there who have made their entire existence predicated on anti-statin rhetoric. And I feel sort of bad for these people because it's such an irrelevant position in 2025, given that you don't need to take a statin. Like, if I have a patient who pushes back and says, I don't want to take a statin, I don't even engage in a debate. I'm like, no problem. That's okay. Do you agree that you need lower ApoB? Well, okay, yes, I guess I do. Okay, great. Guess what? I got all these other tools here. Never, you'll never see a statin. I'll make sure you never smell a statin for the rest of your life. You will not know a statin exists. Are you okay with that? Okay, okay, that's fine. And so it's just again, when I look at all of this sort of the statin hating that goes on out there, again, 90% of it driven by individuals who probably wouldn't know the difference between acetyl-CoA and HMG-CoA reductase, but probably spend too much time on social media. I just feel like, God, you gotta find a new hobby horse, man. Like, you gotta find something else to hate because this has become totally irrelevant.
So for that hater patient, where would you start them?
Well, it depends. I'm gonna look at certain biomarkers. So I am gonna look at markers of cholesterol absorption, and if they're very high in cholesterol absorption, which we can measure through things like sitosterol and compesterol, I'm gonna start them on ezetimibe. If they're high in synthesis, low in absorption, I might start them on bempedoic acid, but I'm probably gonna be leaning into a PCSK9 inhibitor if they need a dramatic reduction. If they don't need a dramatic reduction, then I would play off the other 2.
So to that point, I am an ultra absorber of sat fat, and I discovered this. I did the Boston Heart test a while ago, and so ApoB is normalist range, but again, this is where, and I know you've talked about this, why the diet wars are completely illogical. If I were to consume coconut milk every day, my lipid panel would go haywire, and it would probably kill me. Versus if I were to have A2 low fat dairy, I'm completely fine. Or eat bison, which is very low in sat fat. Coconut milk, 100% vegan, plant based, will kill me. Bison, can't get enough of.
Yeah, my only point on all of the diet stuff is I think nutrition is a lousy tool to treat lipids. I think nutrition should be used to treat metabolic health, to treat anabolism, to treat cognitive health, uh, to manage enjoyment. Like, there are so many things that we should be thinking about our nutrition for that span everything from pathology to bliss. And I would tell you that, like, if you find lean bison to be disgusting and you'd rather eat a ribeye, you should eat the ribeye and we'll make up for it on the pharma side. And so I always get sad when I meet somebody. I'm not saying that this is what you're saying, but I do meet these people who say, the only way I can manage my cholesterol is eating, 80% of my calories are lettuce. And I'm like, yeah, and you look like you've got about, I don't know, 7 pounds of muscle mass on you, and you look like you're gonna break. What why are you doing this? Just eat a diet that can otherwise support your health, and if by, doing so, your lipids rise, we've got all these tools to fix it. Again, that wasn't the case 40 years ago. So 40 years ago, yes, that might have been your choice. You might have been stuck on the all lettuce diet if your genes were such that you could not otherwise manage your lipids. But again, in 2025, that's not the case. And to be clear, I'm not advocating that people should be mainlining saturated fat or anything like that. I'm just saying, like, pick the diet that leads to amazing metabolic health, weight balance, a feeling of satiation, joy, enjoyment, supports your anabolic goals, all of those things, and let the lipids fall where they may, and then treat them accordingly.
Well said. What's something you've changed your mind on recently?
Um, Recently, well, I've certainly become much more optimistic that there may be benefit in GLP-1 agonists that go beyond weight loss and improving metabolic health, particularly around neuro health. Again, I still remain pretty cautious on that, but I think I would classify it as somewhat promising, at least tirzepatide, and that again, this is something that we're seeing anecdotally, but in very high risk patients that do have elevated biomarkers in terms of, things like p-tau and AB4240 and things like that. We do anecdotally see that a microdose of tirzepatide, low enough that it's not even really materially affecting their weight, is indeed reducing those markers. And again, the prompting for doing such experiments, if you will, is looking at the literature that that at the population level is saying, look, even when you sort of normalize for weight loss, we're still seeing cognitive benefits in these patients. And so, I'm hopeful that a dedicated study is underway. I haven't checked clinicaltrials.gov in a while to see if it is underway. Maybe it is, but it would be interesting to do a study in patients with early MCI, with correct biomarkers to test the idea of a low dose of something like tirzepatide to look at how it might improve those things without dropping weight. Because again, you have to be able to normalize these things for not dropping weight, because the weight loss is a confounder here. Again, I would say 4 years ago, I was mostly concerned that people who were taking GLP-1 agonists were gonna erode all their muscle mass and all these bad things were gonna happen. And I think that can happen if you're doing it incorrectly, but I think that a lot of doctors now, and certainly we do in our practice, we just have a lot more experience on how to help patients use those drugs without sacrificing muscle mass. And it just comes down to a very deliberate strategy around nutrition, protein consumption, and obviously resistance training.
It's interesting anecdotally. There's a couple of people I know who are taking tirzepatide, and is not because they're concerned about their metabolic health or weight management. They're doing it because of the neuroprotective benefits they believe that they're experiencing. Fascinating. A lot of noise out there in 2025, to say the least. Uh, what do you think is overrated and underrated?
So I think that the whole craze around peptides is pretty overrated. Now, of course, the term peptide is a nuisance because peptide simply refers to a short sequence of amino acids. And so there are many things that are indeed peptides that are very biologically active and, totally relevant, right? Like HCG is a peptide. It's a pharmaceutical grade peptide that is one strategy for replacing or augmenting testosterone in men and for treating infertility and doing a whole bunch of other things. So it's a peptide. Yay. I think what I mean when I talk about peptides, I'm just referring to the unregulated gray market of peptides that are sold over the counter. And that's probably the thing I get asked about the most. And I think it is a bit challenging that that we don't have a clear regulatory framework for these things. It's something that I hope is going to change. I think the FDA is interested in providing some guidance around these things, but at this current point, I think it's just very unregulated, which unfortunately I think leads to a lot of predatory behavior. So there are a lot of companies that are out there, selling these things in the shadows because that's the only way they can sell them. And there's a lot of them, so the FDA can't really clamp down on them. And they're making all sorts of claims in the shadows as well, because they can't overtly make claims. And basically people, are making the claims for them on social media and on podcasts and talking about this. And there's peptide clinics all over the place. And while I think that there's probably some biologic activity to some of these peptides, in fact, I'm pretty confident there is, we just don't have a sense of what the purity is of these things. We don't, nobody's done the actual experiment to see how much of the benefit that people reportedly gain is placebo versus legitimate. And of course, nobody's looked at what the potential harm is of any of these things. So I would really like to see this become a more regulated area so that, even, we already know that even when you regulate something, it's still a boondoggle, right? Like everybody agrees that pharma has a bunch of problems, and yet the same people who are so anti-pharma are so pro-peptide. It's like one of the most illogical disconnects I've ever seen.
And like from everything I've seen in social media, BPC 157 is our cure for everything, Peter.
Apparently it is. And by the way, BPC 157, which is kind of an analog of vascular endothelial growth factor, may indeed be beneficial for some things, right? It may be that if you have a musculoskeletal injury that requires a temporary influx of blood flow and nutrients, that BPC 157 could augment that. Wouldn't it be nice to actually have a clinical trial that demonstrates that so that you could be justified in buying it? And wouldn't you want to know that if you're buying it, you're getting pharmaceutical grade, GMP grade material as opposed to crushed bird feathers out of China? I mean, again, like, if we're going to do it, like, let's do it right and not puck around with nonsense,
And so on the flip side, what's underrated?
I actually, and it sounds silly because it comes back to our beginning, I think exercise is underrated. Again, I don't think most people fully appreciate how much a well-structured exercise program is gonna change their life. Not just in the here and now, but in terms of the future, in terms of what it means to how well you will live that last decade of your life. This last decade is coming for us no matter what, and again, for most people, it's just not that enjoyable. You know, they're in too much pain, they're too limited in what they can do. They have to retreat away from things that once gave them joy physically, and I think that we just don't appreciate the fact that this is not inevitable. Parts of it are inevitable, but the entire arc is not inevitable. We do have a lot of control over how we will live that marginal decade, and nothing, I think, provides a greater backstop to avoiding those traditional pitfalls than exercise. So I think while everybody knows exercise is good, quote unquote, I think not a lot of people understand just how much benefit can come from it.
I couldn't agree more. And to close, I think we have to have some fun. Let's go straight to Chevy Chase, Peter. What do you think are his most overrated or underrated roles?
Well, I don't think there are any that are overrated. I think so Three Amigos is pretty underrated. I think, if you go back and watch what he had to say at the burning bush in Three Amigos was pretty remarkable. I think, you and I have spoken elsewhere about our admiration for Spies Like Us. I mean, such such a fantastic movie. As you know, I did my residency in surgery, and it was one of my favorite things in surgery was we would role play the surgical scene, you know, like, and now I will incise. Just cut the sucker. I was merely probing for muscle tone and skeletal girth. It's a new technique. We mock what we don't understand. Chevy lifts his mask. Yeah.
Every minute you don't tell us why we are here, I cut off a finger. Mine or yours? Yours. Damn. Are there any Paraguayans there? Uh,
Yeah, he's gonna cut off my fingers.
doctor? Doctor? Doctor?
Let us take him back to headquarters in Moscow.
Good move. Headquarters. Uh, I have to go with Spies Like Us too. I think it is vastly underrated. When I ever am in, feeling a little bit of blue, I turn that one on, and my wife looks at me like I am absolutely crazy and leaves the room, but I am just there laughing. Uh,
I hope when my boys are old enough, they will get the same amount of joy as I did from those films the first time I saw them.
I know we're running out of time, Peter. Anything we didn't touch on, you'd like to touch on or share before we wrap?
We didn't touch on F1, but I'm not sure how much your audience is into that.
Always a pleasure. Thank you so much, Peter.
Thank you so much for having me.